Hey, everybody, you are watching or listening to Wake Up Call, the podcast, and I'm your host today, Christina Previtt. Today is another edition of the #FemDoctor series, and joining me today is Dr. Siri Chamarti, who is an ER doctor or emergency medicine doctor, and she was blessed with the beautiful name of Siri. So you can find her on Instagram as Hey Siri MD. I have to know, what's life like with the name Siri right now?
I'm sure everyone's phones have already gone off.
Yeah, right? I didn't even think of that. That's so awesome. Your parents didn't realize what they were doing when they named you that.
No, actually, it has like Nordic roots, so like Norway and stuff, but also it has roots in like I guess a few different Sanskrit, like sort of Dravidian languages, and it means gold or wealth. So
well, that's a good name to have. Sometimes people get stuck with names that all the kids make fun of them over. So you got a good one.
I hope so, except now they make fun of me for having the same thing as Apple.
My lawyer brain is turning on. I'm wondering if you would have difficulty copywriting your name or anything like that. I'm sure you have not looked into it.
I
would. That's another conversation for another day. But thank you so much for coming on the show. I'm so interested in what you do, because I feel like your area or your specialty is probably maybe a little closer to what people actually see on television. You'll let me know if that is true or not. And you have to really be on your feet all the time. Like, you have to be able to think quickly and act quickly.
That's pretty true. I'm not sure if exactly it aligns with everything that you see on TV, but a lot of things in emergency medicine, I guess people have a perception of already. Like ER doctors save lives. ER doctors are cowboys, or ER doctors are mostly like male. And it's interesting because when you're actually in the ER, it's so different. People come in for so many different complaints, and very little of what you see is exactly like what you see on television, where you're, coding someone or doing all these crazy things in order to revive people's lives. Most of the time, it actually involves talking to people, literally. I feel like I can maybe count the number of times that I've saved someone's life by maybe doing CPR, but it's the power of communication and the power of, human connection and language is something totally entirely different in the ER. Just telling someone like, hey, did you realize that maybe you shouldn't do what you've been doing? It actually makes a huge difference. And a lot of the populations that I've worked with so far, I have gotten the opportunity to work with a lot of underserved populations who maybe have never seen a doctor in their lives. So they didn't realize that what they're doing, it might be bad, or they didn't have the kind of access to care that you and I maybe have or had for our lives so far.
Yeah, I mean, I'm glad you brought that up, because part of what I'd like to do with this series is have the physicians share what it's really like to do what they do, and not just what we think they do based upon what we see on television. So that's actually something I don't think I ever thought about. And I forgot to mention that you do emergency medicine in New York City, right?
Exactly.
So you would definitely think, me as a layman, I would think that you do get all of these exciting cases, that you're getting gunshots and, stabbings and all kinds of exciting stuff coming in the door all the time. But it sounds like it's not really that.
Not as much. It really depends on where you work. In New York City, the history of New York is pretty extensive, and in the past, I think it used to really be considered like one of those unsafe cities. But I think, since the late 1990s, early 2000s, New York has tremendously changed, and different populations are kind of isolated to different areas, more or less. It's a very diverse sort of environment. However, one area might have like a really high population of people who can't afford $1 million houses, and another area, like, if you are looking in like Midtown Manhattan, Times Square, it's probably going to be the most expensive property, and therefore the population probably has more access to healthcare. And so even within Manhattan, you won't see as much of those, straight up like someone got shot, it's more like, oh, people are getting hit by cars, because there's more cars than there are maybe like guns in Midtown Manhattan that are shooting people necessarily. So in other areas, it's very, very dangerous to even walk. Some of these centers, like roads like Gun Hill Road, aren't just named Gun Hill Road for nothing. So those areas, you'll be seeing a lot of trauma, a lot of those like kind of adrenaline induced sort of things. But a majority of what emergency medicine doctors do across the country is very much so what I'm describing, which is not, unless you are in that one area, like you work in downtown Chicago or downtown like Baltimore or something, like then, yeah, okay, maybe you're seeing like trauma like every patient, but majority of like the population maybe might, suffer from a car accident or, be in one, sorry. And that's more or less common than like someone having abdominal pain is going to be more common than someone having something super life-threatening. So my job is to make sure as an emergency doctor is that nothing life-threatening is going on at that time. And it's not necessarily that I can't always make a diagnosis, to be quite honest. And I think people are really disappointed. Like, hey, you're a doctor, why can't you tell me what's going on? And all I can say is, hey, what I can tell you is that you're not having a heart attack. You're not having a stroke. Unfortunately, I don't know what you're having. Maybe it's viral, but there's billions of viruses, and literally I can tell you which one it is.
So is it your role as the doctor in the ER? It's not your role to do treatment and diagnose them with something. It's just your role to make sure that there's nothing that's going on right at this moment that is threatening your life. Is that right?
That's more or less, it's more to initiate the care for the patient. And most of the times I could tell you I have a good idea of maybe what's going on, or I know what path the patient might follow. Like, for example, I don't know, like someone in their 50s comes in with some abdominal pain. And okay, I like have an idea of like the things I'm looking for. And if I find kind of the things that make me more concerned, I might keep them at the hospital. Therefore, I've already like started them on like a path to seeing some specialists, talking to more doctors, trying to really figure out, oh, maybe is it, things that are dangerous, but, maybe not life-threatening that I necessarily treat in the ER. And then it's really like making sure the patient is okay, because if someone walks out of the emergency department and suffers, then that's ultimately comes back to us. Like, hey, why didn't you make sure this patient wasn't suffering from XYZ that was super emergent for treatment? And I think like right now we serve a really large role in primary care as well, because a lot of what happened with coronavirus is a lot of primary care physicians were more or less cutting their hours or having to cancel some appointments. So sometimes patients come in for less glorious things such as medication refills, but we can do those things as well. And it's really like making sure, like I said, the patient goes on the right path, either staying in the hospital or being observed for whatever is happening or going home safely.
And what about the people you described that are there because they don't have health insurance? What do you do for them, or what can you do for them so that they can go on to see other specialists?
So the ER isn't just medicine. A lot of what happens in the emergency department is social work too. If people don't have insurance, the cool thing about the ER is you can't deny anyone treatment because they don't have insurance. You have to treat every single person that comes through your door. What we can get them set up with the appropriate individuals who are able to kind of tie them into like programs like Medicare, Medicaid, different insurance programs, or like trying to figure out, like if they're homeless, for example, like trying to figure out shelter placement or a plan of care. Like, hey, I know you don't have insurance, but you're something's wrong with your eye. Let me refer you to a clinic that's a free clinic that happens like every Sunday. You should go this Sunday. But what I do know is that it's not going to kill you at this time, but like really setting them up for it, like that sort of care that happens is something that we do in the ER. And also like family issues, social issues, like people, keeping people safe and protected against, you know, harm is like kind of also what we do.
So did you think that that's what practicing emergency medicine was going to be, or was that a surprise to you?
I think it's interesting because a lot of fields of medicine don't allow this sort of patient interaction. There are very few that I would say it's like you really have this opportunity to learn about people's lives in this way. That being said, I think it's a very self-selecting profession. People who do ER might have a keen interest in a wide variety of fields or interest in specific things, but they are required to kind of expose themselves to emergency medicine prior to selecting that field. So rotating through for, you know, training, like before I matched into a training program, I was kind of exposed to this. And personally, I think it's an incredible opportunity and an incredible profession, but it's not for everyone.
You know, I can make assumptions, but I don't want to do that. Like, what would you say are certain qualities that you have to have to thrive in that? Like you said, it's not for everybody. So who's it for?
It's for the quick thinkers and the people who we don't make very long-term relationships with most of our patients. Some of them maybe because they keep coming back to the ER because they don't have no place to go. And then eventually, you know, you really get to know them. But for most of our patients, we meet them in their most vulnerable moments. It's people who like to, who are creative because you have to know how to use the resources that you have, or be creative in like your management or like a care plan, like saying, oh, I know you can't do X, Y, and Z, but why not like W and V, and then maybe we can figure out how to do X. Like, so it's like kind of figuring that out. It's for people who like to multitask, maybe are a little ADHD, but at the same time, very patient. We get a lot of, I think a lot of people have this misconception that emergency doctor are triage doctors. And that's not necessarily like how it actually is, because literally the people who call us this, or the people who tell us, oh, you're just there to triage, just, no, I kind of figured out what was going on. And I said, hey, look, like they need to see you. And therefore they got a chance to see you. So if I didn't figure it out, then they might not be in this path. They might be in a totally different path, and they may not ever find out what's going on.
Is this the kind of area that you could have your entire career in, or does it sort of have a burnout rate?
There is a lot of burnout in emergency medicine, but I think it's because the actual work itself. If you think about normal, quote unquote, normal jobs, like they're generally speaking, people think 9 to 5, 40 hours a week. yada, yada, you know, like you
Mhm.
get your weekends off. And
Yeah.
emergency medicine isn't really like that. It's more, okay, you work a certain number of hours per month or per week, or, you know, a certain number of days. It might not necessarily be 5 or 7 days a week. You do have to switch between doing day shift and night shift in some cases. And that's where I think people really get burnt out is, you know, kind of having your body adjust over so many years, or having your kind of like, you're constantly being flexible about your schedules. Like for you, working a holiday is like, oh man, like no one else wants to work the holiday. Your place of work never closes. It's open 24 hours a day, 7 days a week, 365 days a year. So it needs to be open for that long. So someone has to be there. And I think also the fact that like people don't find what they love in it, truly.
What do you mean by that? Can you explain that a little more?
If you're generally unsatisfied with your job, why would you do it? And maybe they went into it for the wrong reasons, or usually that's not the case. Usually it's just emergency medicine is one of those fields that's very impacted by political environment, social environment. Uh, it's like a field that requires you to be aware of like all of these things in order to successfully treat your patients. And that gets exhausting. It's like
Yeah.
managing so many different worlds at once. Like, oh man, like if I do this, it will cost this patient this much amount of money, but I know that they can't even afford to pay for a Uber to get to the ER. They took the train like 2 hours to get here. Like I don't want to do that to this patient. What if I think about like what plans exist right now, or how their plans will change, or, you know, like it's
Yeah,
kind of
I
like,
guess that's not something that if you're working in a traditional office and you're a dermatologist, for instance, because I just went to the dermatologist today, and you know that you're not going to deal with that because they've already shown their insurance card before they even got to you. So those just aren't considerations that you have when you're talking to a patient, right?
yeah. Also, I mean, you always do what's best for the patient, but when you have the patient's best interests at heart, a lot of things go into it. There's a lot of socioeconomic determinants of health that exist in the ER. And unfortunately, just thinking about some of those determinants, like, hey, if I, just the most simple example is a homeless man, I don't know, trips and falls and has a laceration on his scalp. And you can't rely on this guy for some reason to come back to your emergency department because he's never been there, and he maybe is like, you know, actually like lives on the streets like 20 miles away, but he's just here. So you just have to think like, oh man, do I put staples in it? Because the staples could get infected, but I don't know if this guy can come back or go to any other shop. Like he's homeless. Like
Yeah.
what, you know, what, and like, what do you do? And what, even those small considerations like make a big difference.
Do you often encounter people with mental health issues, and what do you do under those circumstances?
It's treated like normal, and like we treat any other, you know, conditions. People, it's not rare to see people who have uh, you know, have different issues going on in their life and that cause them to feel a certain way, or come in with like, you know, suicidal ideation or suicidal attempt, depression. I think it's really important that we make sure that they're not a threat to themselves or a threat to anyone else. And a lot of it is we use our psychiatry consultants in the emergency department who are specially trained to determine you know, certain facets of patients kind of like history and whatnot, to kind of make that determination on if they're really okay or not, or if they need to be hospitalized and treated in the hospital.
Well, it seems like you have to know so many different areas. You know, if I go to a dermatologist or a GI doctor, it's for a very specific thing. But it seems like you have to know all of it. So at what point do you refer it to another, maybe a specialist that's in the hospital? Can you explain how that works when someone goes to the ER?
Sure. So I think people who come to the ER have a very specific complaint usually. We do know, as someone called it recently, is the best 5 minutes of every specialty. So we know like the best 5 minutes of dermatology, maybe not, but I don't know. Or like the best 5 minutes of cardiology without dealing with, you know, all the chronic issues that come with it, you know? So we know enough to take care of a patient, and we are constantly reading, constantly learning. Being a doctor isn't easy, so we constantly have to update our credentials, keep up with literature, new studies, and whatnot. In terms of referring it out, it would really be, is it an emergency condition that we need to manage now? For example, if someone had a prolonged erection, it's called priapism. And that is a medical emergency because you could potentially lose that area of your body because it's been going on for yay many hours. That is an emergency, and we're able to deal with that in the emergency department. But if we have consultants in the hospital who are urologists who specialize in it, they can also come down and deal with it. But say you're just coming into the ED because you're having issues in your sexual life, then that's maybe not something that we necessarily deal with in the emergency department. And we would say, hey, you know, it's not really life-threatening at this point. You need to go see a urologist.
Well, I certainly was not expecting that subject to come up. Is that something that you had recently, or is that something that happens often?
It doesn't happen very often, but we are trained in dealing with it. I'm just saying like that's like a really easy example to give, I guess, because I did encounter this when I was a resident, or not a resident, sorry, a student. When I was a medical student, we did have a case where someone, unfortunately, for a adverse reaction of a drug, had a prolonged erection for almost 2 days.
Wow.
Yeah.
Why is that life-threatening or
because,
penis-threatening?
Just keeping it interesting for the audience. So basically, if blood doesn't flow to any part of the body that it's supposed to continually flow through, then that's a problem. Like if blood stopped flowing, things become stiff. So a prolonged erection is just like where your blood isn't flowing the way it's supposed to your penis. Therefore, all of those tissues, they're kind of dying in a process called necrosis. So it can either happen in the veins or it can happen in the arteries, like your vasculature, essentially. So that's essentially the bad part about having that condition. And so what you need to do is you need to go and kind of drain that blood out that's stopping new blood from flowing to these tissues that really need it in order to preserve all that area.
Oh man, that sounds rough. Did you ever have to do that procedure?
Well, the case that I had as a medical student, we did go to the operating room, and we were in the operating room for about 2 hours trying to kind of drain all the blood. And even at that point, it had been a few days. So
I have to ask you, when something like that happens, I mean, to me, it's funny, right? And is it funny to you at the time, or are you just so focused on the emergency that you're not really, you're not thinking that it's funny? Or are you thinking it's funny? I don't know. I mean,
most of the times I question, how did that happen? I think the more funny things to me are things like people can't or that people can control are the things that are funnier to me. Like, for example, this guy, he had a adverse reaction from a drug. He couldn't control that. That wasn't something that he knew would happen. But like people who come in and they fell on an object, and I'm like, I'm fairly certain it's very hard to fall on this particular object for it to end up in your anus.
Yeah.
That's not common. Like, that's more funny to me than like, say, oh man, I feel really bad for this patient. Like, he just did what he was supposed to and he ended up in this bad situation, versus there's a stereo in your butthole. What would you like me to do about that?
Yeah, I feel like this conversation is degrading, but I'm going to go with it. What kinds of things have people put in their butt that you've seen?
Lots of, like, literally, you name it, they probably have tried it.
I think you mentioned a tube of lipstick to me the last time I talked to you.
Like lipstick, lotion, I don't know why, utensils, very like common household things, I think, are the most common kind of things that are found in there.
So how do you get it out?
Sometimes we're able to retrieve it, and sometimes we're unable to retrieve it in a safe setting. So then at that point, you do have to get surgeons involved. And
so basically you put on a glove and dig in there.
Sometimes if it's not deep enough, if it's too deep, unfortunately, that kind of is outside my area of expertise.
Yeah, I mean, inquiring minds want to know, Siri, because we can't start this conversation and then, just end without these questions answered.
No, I think these are great questions. And honestly, that's what makes my job really, actually, it's kind of rewarding. Like, foreign body removals from yay here or yay there are actually really rewarding because you fixed the problem. Like,
yeah.
Oh, okay, you had a chicken bone in your throat. I got the chicken bone. Okay, great. You feel better. I did my job. You feel better. We're both good. Bye. But
yeah. Doesn't sound like those are boring at all. But going back to the question, I mean, have you ever had to really fight the urge to laugh during some of this?
I have. I really have. Sometimes, luckily now we're all wearing masks, so I can smile or laugh or just think you sound ridiculous underneath a mask. But most of the times, honestly, I really feel bad because a lot of people, like, the reasons they come to the ED aren't really because they want to be there. And I really sympathize with that. And I feel bad that they are there. But
well, imagine how embarrassing it must be for them to go into the ER and say, I put this in my butt and I can't get it out.
Usually they don't say that.
Yeah, I was going to ask you, do they admit that they make up a story, right?
Yeah. Oh, I just fell in the shower. Really? Explain how this fall happened. No, I mean, it's not my job to really, inquire about that. It's more like my job to make sure that they're okay. And I'm actually happier that they came to the emergency department to get help than I am that they stayed home and developed like an infection and later came in when they were super sick, almost about to die. Because then at that point, it's going to be harder to help them than like, hey, I know it's embarrassing, but you really have to explain to me why the CT shows that there is a fork in your anus. Like, you just really have to tell me how that got there, What?
How did that get in there? Yeah, it can be embarrassing. I mean, I feel for anybody who's in a situation like that because I think as human beings, we've all had to go to the doctor and talk about something that was just sort of embarrassing. It's amazing that we're all human beings. We're all having a similar experience, right? But bodily functions are still embarrassing sometimes.
Mm-hmm. And I feel like people apologize for puking. And I'm like, that's okay. You can puke. I'm okay. Like, here's a puke bag, like puke.
Yeah.
Or like anything. Oh, wait. This is my 15th time today. It's like, it's okay. Go poop. do your thing.
Yeah, it's sort of a private thing. We're taught, you poop in private, you go to the bathroom in private. I mean, if you have to throw up, I think it's generally something you kind of want to do without everybody watching you, right? So, and then you have to go to the doctor and talk about these things. And it can be uncomfortable. So, but I don't know. Are you ever, well, I've always said that doctors really just look at us like we're a piece of chicken. Like whatever they're looking at, whatever body part, if it's your privates or whatever, they're not sitting there judging like, oh, wow, she needs to shave, or, that's interesting. I never saw that before. Am I right? Please say I'm right. I would like to be right.
Yeah, I rarely remember what patients honestly look like after I document it. It's okay, I don't think of it in that way. I think of it more of as a, oh, okay, what am I looking for here? If someone comes in with a chief complaint, they say, I have throat pain, I'm looking at your throat, oh, okay, I'm looking for specific things. Do you have pus? Is there redness back there? Is there certain things that should make me more concerned that there's an abscess back there? I'm not looking oh, they ate spinach and there's spinach on their teeth. What? How could they open their mouth? No, it's not like that at all,
Well, thank God. For everybody who's ever worried about that, there you go. There you have it.
Yeah.
So I feel like we just dove right into your work as an ER doc, but I wanted to also talk about you personally and your education. Did you always know that you wanted to be a doctor?
No, actually, I was dead set on doing everything that didn't fit the norm. I think I wanted to explore all my options before I made up, my mind. Initially, I was thinking I could be a politician. That didn't go so well.
Did you actually try that?
No, it was in high school. I was exploring all these things, and I joined the Model United Nations. And I was I so can't be a politician. I don't know what all these policies mean, and all these words on this paper just confuse me. This isn't for me. I tried law, and then I was it's not for me either. But I really liked certain aspects of each field, and I didn't know exactly, I think, what I wanted to do, to be quite honest with you. But I wanted to have a job where I was able to do anything at any time, if that's what I wanted. And I think the coolest part about being an emergency medicine doctor is that you can do anything at any time. It's really related to every single part of your life. If I wanted to go be in the military, for example, I could go be a military doctor at a base, or, join the military. I could, if I wanted to be a journalist, I could be a medical journalist. Emergency doctors are great for medical journalism. If I wanted to go, just anything, if I wanted to do business, I could be in hospital administration, because I know how all of the consultants operate their fields, in addition to the emergency department, which is probably it's the way that patients come into the hospital. Over 90% of patients come through the emergency department in order to be hospitalized. So it's really whatever, if at some point I feel my career as a doctor is not that fulfilling to me, and I decide to pursue education, I can always work in education for medical school or whatnot. So I think the fact that my avenues are open is something that kind of pushed me towards a path in medicine, but specifically in emergency medicine. And also, I also want to be able to be hey, I can help you if there's ever a in-flight emergency. I'm a doctor, but also the doctor.
I'm a doctor and I play one on television.
Exactly.
Have you ever been on a plane where they would ask, is there a doctor present?
I think before I actually graduated medical school, but I never had I don't seek those opportunities.
You didn't raise your hand?
Yeah, I think I was like a pre-med at the time. And I've definitely had friends who've encountered situations on planes, but if you had to be in any field of medicine that would prepare you for literally anything to go on anywhere at any time, this is the one to be in. Also, I decided sometime as a pre-med with all those crazy shows on TV that I wanted to survive the zombie apocalypse. I was like, you know what? Let me just do the most practical thing with my life. And whatever that is, I will be able to survive. And quite literally, like COVID has been that. It's like, oh, can you survive like, people dying in front of you, like left and right? Can you survive who's infected, who's not infected? Can you survive like dodging like bullets? Like,
yeah, some people are comparing this to the zombie apocalypse.
Yeah, it's essentially it's not like that, but it's essentially like this is the modern version or the maybe pre-zombie apocalypse.
Yeah, who knows? Well, 2021 was interesting, and 2020 was interesting, but 2021 started out very similar to 2020. So we'll see how things go this year. But so when did you decide that you wanted to be a physician? Because it sounds like you were on a pre-med track in college.
I decided I wanted to major in, so I didn't know that I was going to exactly do pre-med. But I know meeting the requirements for doing pre-med means that you could do many other things still.
Okay, so you weren't set on going to med school necessarily while you were in college.
Not until I think the end of my first year. Like, a lot of people, they go in and they like sit down next to you in chemistry class and they're like, I'm going to be a doctor. And I'm like, this is the bro, literally shut up. I'm just trying to shop on Amazon right now. No, for real. So it's very, I went to a public school my entire life. And I think that's something that taught me a lot. It taught me a lot about like public education in America. I went to a public college. I went to a public medical school, how resources are allocated to different institutions.
Where'd you go to school?
I went to school for college.
And med.
For college, I went to UCLA, and for medical school, I went to the Medical College of Georgia. So I was in state at the time for both colleges. So honestly, that was a huge factor in choosing, whatever I did.
Yeah, it's expensive.
Not affordable to do a lot of things. Like a lot of people will say, hey, look, I can't afford to pay $70,000 a year for a education and yada, yada, because, yada, yada. So I think the fact that I went to a public college, I had a class size of people, my peers, was like 4,000 people or 5,000 people who were in my class. So that meant like 4 years of that. So 20,000 people. And at any one time, there's so many people around you and they're all doing incredible things. You're exposed to so many different pathways of what to do. And I entered college as a neuroscience major because I was interested in all the cool things that were happening with like artificial intelligence and whatnot. And then I very quickly realized later on that I was not very talented in the field of mathematics and physics.
That isn't being a physician a lot of math and
not only some fields, if you're doing like nuclear radiology, but I don't integrate things on a regular basis. I mainly just multiply by 6 for like a heart rate and like and add things.
Well, there's sort of this joke with lawyers that we went to law school because we weren't good at math, because if we were good at math, we would have gone to med school. So it's really interesting that you're saying this. So now I can tell people, well, you don't necessarily have to be good at math. But you have to
No.
take all the sciences to even get in. You have
You
right?
have to see all the sciences and you have to understand them conceptually, but many fields will not require you to do multivariable calculus on a daily basis. I just do a lot of multiplying, dividing, adding, and subtracting. And that's very basic. Like I could do that. Like, oh, okay, like this patient's, let me calculate yada yada about this patient. Or it's amazing with the internet now is I just punch in some numbers and it'll do it for me. But like conceptually, I understand what they're doing. It's like, oh, they're calculating this circumference for this reason. Okay, like I know how to calculate a circumference, like, but it doesn't mean that like, necessarily that I have to do it by hand or anything.
Yeah.
I think it does. I think that part of like being a physician, like I said, opening my eyes up to so many different fields, I just really wanted to be able to do anything and have those skills to be so flexible in what I really wanted to achieve. I still feel like I'm relatively early on in my career. I know that I have the power and the opportunity to change lives, but in what capacity that will kind of manifest itself in the next few years, it will be all, I think, determined on not only like it will be determined on our atmosphere, healthcare atmosphere. And that's something that I too feel like I have a opportunity to be involved with.
So tell me what it's like to be an ER doc during COVID.
It's surviving the zombie apocalypse.
Yes.
No, so it's actually really it's actually super it's super crazy to think that such a thing has happened. A part of emergency medicine is solely dedicated to the study of disasters. It's called disaster medicine. And basically, in this kind of area of emergency medicine, people describe how to allocate resources, how to triage, how to like really do the most good for the most number of people in a mass casualty event. And I feel like COVID is essentially a mass casualty event. It's what we train for in a medical, like in emergency medicine. Like it's something that we feel like prior to COVID, I feel like, you saw a lot of complaints, but you never, maybe the last mass casualty that New York City specifically has had was September 11th. This is something that kind of hit us like shockingly very hard. And we were one of the first people to be hit as well. So we had no idea what we were doing because it came to New York City in March and April. So being an emergency medicine doc, how that changes your life is now there's a new threat out there, like a virus, like all the movies and TV shows describe. And we have no idea how it works. And we're just trying to figure out, does it work kind of like this disease or does it kind of work like this disease? And what we're doing is we're basically like saying, hey, the patient's condition is such and such. This is what we're seeing. This is what we have to treat. Like we're just treating what we can see, but we don't really know what that is. All I'm saying is like, okay, like this patient is literally crashing, meaning their blood pressure is dropping rapidly, their heart rate is not keeping up. So we are giving them medication to maintain their blood pressure and maintain their heart rate. But at the same time, we don't know why that's happening or what's going to manifest itself. And that's what happened in March and April. And slowly we learned a little bit more and learned about the therapies that worked and the therapies that didn't. And the things that we may have necessarily done then, we're not going to do the same things now. So it's a lot of like trial and error being an ER doctor. But I think being in our fields, we have that mindset that, okay, like, all right, fine. Like, you don't want me to give them the green pill anymore. Okay, fine. I can give them a blue pill. Like, I'm open to that, like kind of new management or like new way of thinking. But it's really like been kind of incredible to see how like science has truly like kept up in this regard.
Yeah, I mean, it's evolved a lot, it sounds like, since March. Well, I guess it was around before March, but it seems that it has evolved a lot. And I don't understand the nuances of that the way that you do as a doctor, but it's definitely something we've seen all over the news. And I think a lot of people are in a panic over it, especially now that there's supposedly this new strain that's more contagious. Are you seeing any of that? I actually don't know the current news on that, whether we've seen it here in the US, and if we have, how many cases we've seen.
I think it got reported in a few states, New York included. Unfortunately, in the emergency department, we don't test for strains. So I couldn't tell you like, oh, this patient has this strain of this disease. That's something that I think that like public health more so monitors. But what I can tell you is that people have the right to be anxious, to be fearful. And I honestly feel like it's actually the people who are not seeing the realities of what kind of panic this is causing. And like, it's kind of those people who are maybe more so a danger than people who are like, hey, I'm going to isolate myself. I'm going to socially distance. I'm going to wear a mask. Like just the simple, like, thing of wearing a mask and standing 6 feet away from each other. Like I respect every single person who's done that, because for the people who haven't, they've unfortunately, like you'll see like people who are very prominent who didn't believe that such a thing was happening, and then they're in our care, and then we're like, well, it's not great to be in this care because we still are trying to figure out the puzzle and the pieces and the treatment. So
was there a period though since March where you were at capacity in your ER?
I think mainly in April, and even since then, I think here and there have been times where we've been hitting after Thanksgiving, I think a little bit. Specifically, I think that unfortunately it's linked a lot to social distancing. So the holidays weren't exactly, didn't do great things for, the spread of this disease. And I think a lot of people feel a lot of pandemic fatigue. It's a phrase used to describe the sort of conditions this pandemic has caused, and people just being like, yeah, now forget it. I'm going to do whatever I want now. It's been 9 months. Why should I continue doing this? Like, so.
Yeah, it doesn't really make sense.
I think it's hard because now finally, like as of mid-December, we finally have an answer. And that's, no one gets this. Like just no one get the disease and we'll be okay. And that's going to be impossible. Like smallpox took like 100 years or something to eradicate. It's going to take a long time for this particular virus to be eradicated, but in order to control the rates and kind of make it more so like something manageable for the healthcare and for people, like to keep people safe, because unnaturally we've seen people die of like COVID that were otherwise healthy, like 30-year-olds, 35-year-olds. They don't just die. Like they have a long life ahead of them. Usually the number one cause of death in this population is like motor vehicle accidents. Like, so it's something that I think will be, something we look back on in the future. Like, oh, okay, I'm glad we did that. Like, I'm glad we socially distanced. I'm glad we got the vaccine.
Yeah, better to be safe than sorry. And that's a popular misconception, I think, with the younger crowd. And younger, it's always relative, but I'd say 20, 30-year-olds. I've heard so many people younger in that age group say, I'm not really that worried about it. I'm young and healthy. And if I get COVID, it's, I'll be fine. I'll just recover from it. So I'm glad that you're pointing out that there have been healthy people that have died from it.
Definitely. I think it's actually like over the news, and some of the people who, it's hard to imagine that it could happen to people who are otherwise young and healthy. No, medical problems. In most cases, yeah, like, okay, fine, you might have like some cold-like symptoms and recover, but what if you're one of those people who goes into severe pulmonary failure or heart failure, or what if you're one of those people who requires a heart transplant? Do you know how hard it is to get a heart transplant or a lung transplant? It's insanely hard to get, like, that kind of that's like, the worst case scenario, right? Versus like, oh, I'm just happy that I like socially distanced and wore my mask. Like, I'm just happy I wore my mask. Like, that could be like the minimum that you do.
Yeah. Did you get the vaccine? I think I saw on Instagram that you did.
I did. I got the vaccine. I'm due for my second dose soon, and I'm super happy that I did, because I work in a very high risk situation. But also, like, I would have gotten it even if I was a normal.
Well, I'm perplexed by all the people expressing concern about getting the vaccine. Just saying that they don't feel like, and these are laymen, not doctors, saying that, it hasn't been tested sufficiently, and I'm just going to wait and see what happens to everybody else, which I don't like. What are we waiting for? To see if they die or throw an extra head or something? So what would you say to people like that who are doubting whether the vaccine is really safe?
So vaccines still, even though it was emergency authorized approval, right? It still needs to undergo a rigorous process of testing and whatnot. And I totally get it. Like, it's okay to have vaccine hesitancy, which is the term we use to describe like all those feelings. But I think that seeing kind of the outcomes of actually getting the disease, getting the vaccine, most people have reported kind of minimal side effects. Like, hey, had some body aches. I had some arm pain. Like, I'd rather have arm pain and body aches than require, than get the most severe form of the disease. Also, it has been tested. The technology people are very hesitant to accept. The only reason other vaccines weren't actually made in the same way is because it's very impractical to have a vaccine stored at such a low temperature. And once a vaccine vial is opened, it has, I think, like 5 or 6 doses. They all need to be used and or discarded at the end of the day. So having said that, like, it's impractical, for example, for a drugstore necessarily to store a vaccine at -70 degrees Fahrenheit and only open the vial if like 5 or 6 people need it. Like, just think of any normal vaccine, right, that you get as a child, or even like, the flu vaccine or something. So that's why, like, most vaccines, that's not the preferred route. It was most vaccines like are not the same way, but they don't change your DNA. It's just different technology. And this is kind of the most effective way to prevent the spread of this disease. You'll see a lot of healthcare professionals lining up for it because they understand the kind of the technology, and they understand that, hey, this is safe relatively. Most vaccines, give or take, do not have effects in the long term. Like, people, I don't know what people are waiting for. Like we won't know what's going to happen in 10 years from now, but most vaccines, the effects that they're going to have that are like side effects or negative effects, usually in the first couple of days and weeks, like, oh, okay, you've had some arm pain or whatever. The only effect that they're really, really supposed to have long term is immunity, which is what you want.
Yeah. So yeah, I'm with you. I don't know what they're waiting for either. I mean, whatever that is, it would be 10 years into the future or more. So are you going to wait 10 years to get the vaccine? It really doesn't make sense.
Yeah. Also, people don't believe in big pharma in America and of healthcare in America. And I think, unfortunately, that does impact the delivery of care and also the public perception of public health in America.
Yeah, I think you're absolutely right about that. We all know people that believe in conspiracy theories between the government and big pharma and I know people that won't get flu shots because they think it's just a big scam for, between the government and the pharma companies to make money. I get my flu shot. I haven't had the flu in years. So, but I think everyone's entitled to their own opinion. I'm just saying I disagree with that. Can kids get the vaccine? What's the age limitation?
I don't actually know if they were approved, but I could tell you that it's not even to be withheld from pregnant patients as well. So probably safe, but right now we're not at that rollout process for kids yet. Soon it will be, I think, for kids. So
what's the cutoff though? What's the cutoff age? What's the youngest you
I'm gonna have to look at it. I don't think there's a specific, it's like 18 if I had to guess. I didn't actually read through like exactly because I don't have children myself, and I don't actually work in public health, but I do know that it's been shown to be safe in adults for sure. Okay. There's probably going to be recommendations for school age children coming out soon, because I know that certain states, either their schools are still open or they're very anxious to get kids back to learning, because a lot of school years have been lost during this time that, there's been social distancing and Zoom learning.
Yeah, I think the kids are having a hard time. As much as it was a fantasy in every school kid's mind to not have to go to school, I think now that they're actually not going to school, I think they miss it, and they miss the contact with their friends and just having a normal routine. So I think it's important to get the kids back to school.
I think it should happen in a safe manner whenever kind of people determine that, state.
Absolutely. So you and I, when we first became acquainted to talk about this podcast, we agreed that we were going to talk about doctors and the way that they are portrayed on television. So what is your feeling about that? Are there any shows that you think are realistic? And which ones are particularly bad, if you have an opinion?
There's so many shows out there. I would lie to you to tell you that I didn't watch ER, but I did watch ER, and I actually really liked that show. It was it was in the early 2000s, more so than now.
I don't know. It was on a really long time though.
It was on a really long time. It was okay. I wouldn't say it was very realistic to today's time or unrealistic. Sometimes I think Grey's Anatomy is
not at all.
No, not. I think it's it overdoes the drama. I feel like maybe it's applicable in the surgical field. Yes, surgeons work very hard, and I'm sure it's actually against hospital policy to hook up with your attending, or what I mean. It's most hospitals have rules in place where that's considered not cool. It's professor student relationships,
I mean, do they take that really seriously though? If you get caught, do they get fired?
I think they take it very seriously. There's been definitely reports. It's almost considered assault. Yeah, but I mean, also it's not it's just the way they portrayed in that show, I think, is particularly deceiving. You could do whatever you want whenever you want, and there's no consequences. And I think that that's wrong, because you'll watch, if you read the news, even it'll be oh, so and so doctor fired for assaulting residents or students, or it's technically if it's not mutual, not consensual, whatever those criteria are, then it's against the law. And it's also a form of I guess subordination and using your power for whatever.
Kind of like Bill Clinton and Monica Lewinsky.
That reference is so 1990s, but I totally get what you're saying.
Are you calling me old, Siri?
I said it was 1990s.
I'm just teasing you. Yeah. No, I get it. There's sort of a power imbalance.
A power imbalance. But you know what? I think for people who glorify the medical field is oh, these doctors are so cool. Some people aren't really that cool. Like, you're just like, all right, well, it looks like you read the textbook. Well, it was nice to meet you. Thanks for telling me about nothing else interesting. But it's like, like not everyone has this personality. Like, there's definitely personalities. I think it just comes by fields, and it's like portrayed in a very different way. I think Scrubs is probably it's actually a pretty accurate show in terms of medical education. Like the content itself, it shows someone progressing in their career as a doctor from being an intern, which is like that level of training right after graduating medical school. These are their first experiences as doctors. This is like their first time doing something. And I think that that showed what it does really well is not only both the like medical content, but also some of the adjuncts to medical content. So like in Scrubs, the guy counsels someone on smoking cessation for the first time and is so convinced that this patient has listened to him. Like, like I tell my patients all the time, like, hey, you should stop smoking. It's probably not doing great things for you. You're already on oxygen. It's probably not going to do great things for you. But this guy in Scrubs, he's so convinced that he has made this patient quit smoking, like a 20-something-year-old. And he goes and sees the patient smoking in the hallway. And then he's like, oh, damn.
Yeah, they don't listen, right?
There's this like cynicism associated with like how much power you think you actually have versus how much power you like. I don't know, if someone tells you something, you might like, take it into consideration, or you might shrug it off. And it really depends on your knowledge and your trust and, how seriously you take things that, you say to people or like things that are said to you. But I think it portrays that aspect of medicine, and also kind of the bonds between different people, like being co-residents or different specialties really well. The Resident is probably the newest medical show that I'm kind of aware of that shows a training necessarily I think it's like some of the actual medicine is fine. Like if you're really concerned about like someone who might have a compression fracture, you should do a rectal exam. And that's what the guy tells the intern, like, hey, we're going to figure out if this guy is actually having, what they say they're having. Let's get your finger all gloved up and shove it up their ass.
Like, oh my God, I would never have ever put those two things together.
But it's actually like a medical thing. Okay. Like I get it, but they portray medicine in such an, I think they like exaggerate at times, like, but at the same time, like that's kind of reality. Like if your heart is fluttering really like rapidly, some of the things you might consider doing is putting ice on your face. But what they do in the show is they take a bucket of ice and they just dump it on the patient. And I'm like, I don't know if that's how I would have put ice on their face versus like if I've done this before is I got like bags of ice and I just kind of hugged it to like their cheeks or their head or, it's different, like the way they portray it, but it's like actually medicine still. And I think that show also, it portrays like an aspect of medicine that's really critical, I think, in your development as a doctor, which is residency. It's like that glorified like time and training really well, actually. So
okay, I'll have to check that out. And actually another doctor that I interviewed, Dr. Supriya Rao from Boston, she said that she also thought Scrubs was the most realistic.
I think it's probably the most realistic and the most medically like accurate. And also, like I said, the whole cynicism. House is just good cases. Like,
yeah.
But literally, like if you treated patients like House treated his patients, like you would not be hired for very long unless you owned your own practice. Maybe, I don't know.
Yeah. How do you learn about, or do you, other than just doing it, how do you learn about bedside manner?
It comes down to personality, and it also comes down to practice. And it also, I think it's not a learned skill. It's actually, if you think about it, most of the medical field is customer service. And if you have done any customer service job ever, then it kind of helps you provide bedside manner. If you were like a waiter or a waitress, hey, listen, like you got like half of like what you're going to tell the patient down already, because you know how to say things to people in a way that they will listen to you. Or, oh, I recommend that you get the olive omelet. It's like the special today, versus like saying, hey, I really do recommend you take these antibiotics because you have pneumonia. You got like the skills kind of like set, you know, you just have to replace them with medicine. And also, I think the hardest part about medicine is like talking about uncomfortable topics, especially in the emergency department. And like you said, people don't want to talk about their bowel movements. People don't really want to talk to you about their drug use, but it's so important that we actually know like what's happening, because we will just be perplexed, or we'll do a urine tox, which will show us like, you know, oh, you should probably told us that you use these drugs before, you know, we give you any more to help you out. So it's, we're not here to judge people in the emergency department. Like, I think that's something that's a misconception. Like you said, like, oh, they'll say something if I say this. I probably heard a lot of it. And honestly, I'm not too surprised. Like, okay, fine. All right. I know that, you know, you decided to, for some reason, kiss amoeba the other, or not amoeba, you know, like, you know, kiss a fish the other day, and you decided to lick it dry. Probably explains why you have an infection. But you know what? Whatever. Like, let's figure it and move on.
I'm not going to admit that. Something I've often wondered, though, when I see this on television, I don't know if this is reflective of what really happens, but they'll start asking questions with somebody else in the room. And sometimes I'll think, well, maybe they don't want to answer those questions truthfully with that other person in the room. Like if you have a 19-year-old girl who's got abdominal pain and you want to find out if she's sexually active and her mother is standing there, what do?
You ask them to leave the room.
So you ask them, because one time I had a situation where, and my boyfriend was in the room and I didn't care, but the doctor said, he asked me if it was okay for my boyfriend to stay in the room. And luckily the answer was yes, but what if it was no?
Then you could just say, hey, like, can I ask you to leave the room so that I could finish my exam or whatever? Sometimes,
yeah, but I guess like my point is that if I didn't want my boyfriend to know that I didn't want him in the room, he didn't really give me an opportunity to do that. Do you know what I mean? Like sometimes you want, like, I'm wondering if you have to strategically assess when you're in a consult or whatever you call it, that, you know, there's another person in the room. I'm just going to ask him or her to leave. Do you do that?
Sometimes I do. Or sometimes I'll be like, hey, if it's like a pediatric patient, unfortunately, they're under 18, unless it's like a very specific set of diagnoses, like we have to disclose things to parents, but sometimes you don't have to disclose whatever they tell you to their parents. And you could be like, hey, you know, I know you told me you did weed and that's why you feel so high and paranoid right now and your mom is really worried about you. But like, and you say this like while saying, hey mom, I'm just gonna walk them over to check their heart rate over there. Like, and you like walk them to like another end where the mom is not there, and you're like, hey, listen, like, I could smell it. I know you did weed. Like, listen, like, just tell me what like is going on, because I don't really care. And you should probably tell your mom, but I'm fine to not tell your mom if it's not gonna. Doesn't mean that it's gonna be like a life-changing or management-changing thing.
Yeah. I mean, I would think the hardest thing is just sometimes just getting people to be honest about what they took, what they did.
It's hard. I think they tend to be more honest when they know that whatever you tell them, you can't tell other people. Like, you could be like, hey, I've asked your entire family to step out of the room, or, and they're waiting in the waiting room or something very far away. Like, can you please tell me like what's going on? And I don't have to tell your family necessarily what all is happening. And I can tell them just that you're doing okay if you want me to. And I think people tend to trust you more. Also, I think having like relatable experiences or something, be like, hey, I messed up too. Like, I feel like sometimes some days you just don't feel well. Like, it's okay. Like, you don't always have to be like the strong one necessarily. Like, you can ask your son to step out of the room. You can just tell me like, hey, I'm having difficulty at work and not making enough money, or, you really try to like understand where people are coming from.
Yeah. You probably get good at reading people too, I would think.
I think that's a skill that you should come in with, but
you're probably right about that.
Yeah, you get better at reading what their true intentions are. Like the way people say things will I think either trigger you or it'll be like patterns of like speech that you'll kind of get used to. Like if someone asks you, hey doc, I'm just in a lot of pain, and you're talking to them and you're pushing on their belly, but you're like distracting them and there's really no pain there. Then you're like, okay. And then you're like, okay, fine. Like I'll get you some pain medication. But then they're like, no, I want this opioid medication. And then you're like, yeah, I don't know if that's going to work out today. Or you get really good, I think, at figuring out why people are there. And I think it's really important that you do, because why do people come into the emergency department at 3 a.m? They're either dying or there's something like seriously wrong with them. People who come in for screening exams, I'm like, wait, you're here why? Do you need access to like a provider who could help you? Because I don't know if I can necessarily address your 6-month hair loss today at 4 a.m. Okay.
Yeah, well, that's where, sometimes the mental health stuff comes in, right? Like maybe this person just has a mental health issue.
Or maybe there's like something seriously going on. Like, oh, maybe they come in there being like, yeah, I've been losing weight or like losing my hair for 6 months. And then you'll notice that they're really quiet around their partner, or like, you'll be like, hey, like, are you being abused? Those are like also, I think, the things that we have to screen for and be really aware of.
Yeah, that's a really good point, because we know that's prevalent.
Unfortunately, with the pandemic, more so than, it's like so unfortunate, because I think people are in like closed spaces. Like you don't know, like maybe this is their only escape to somewhere safe.
Oh, that's so sad.
Yeah, it really is. But the ER is a safe space, and we do our best in the ER to try to actually figure out why patients are there, medical or non-medical. And I think we really try to help as many people as we can. And believe it or not, I don't want you there any longer than you want to be there. And I think people are like, oh, why hasn't the doctor told me about these results yet? Why hasn't the doctor done this? Like sometimes, they get really angry, and I'm like, hey, I wish I could, make this test happen faster, but that's just not how it works. It takes time, unfortunately. And I think the other thing people expect from us is that we do everything so quickly. And sometimes if we don't have those resources, then that's not happening. Like someone comes in, I don't know, for like hemorrhoids or something, and they expect all of their pain to be gone. And I'm like, it's going to be there for a little bit. Like the reality is that we're doing the best we can with what we have. And you might need to see someone outside the hospital at a different date in order to really fix the problem.
Yeah.
And sometimes we just put like a Band-Aid, like, all right, so actually this is going to kind of help you, but what you really need is this and this and this.
So are you a lifer in emergency medicine?
What do you mean?
Do you think that this is it for you, or do you not know, or do you sort of have some ideas what you'd like to do?
Most people who do a certain field stick with it. Very few people that I know have ever transitioned between fields because you have to go through extensive training. For me, this is something that makes me happy. I like it. And honestly, like, what I like about it is like the fact that I could always work part-time. I never have to recruit patients. I feel like patients just come to the ED because they need help. And there's always going to be people who need help in more ways than one. So I feel like for me, this is probably what I want to do. What exactly I'm going to do with it, I don't know. Maybe in the future I'll do something like I might like travel or something and practice emergency medicine, or I might, I don't know, want to like write and like practice emergency medicine.
Write a book.
On what? it's
all of your experiences treating penises and anuses and things of that nature in the emergency room.
Is it too vulgar?
People would, I mean, I think people are genuinely interested in what kinds of things come through, because one of the things that I do as a divorce lawyer is I do get to hear really intimate details about people's lives that they're not generally advertising, you know, maybe not things like that about their bodies, but things about their finances, their feelings, you know, if they've stepped out on their relationships and things like that. So, you know, I think there's the same sort of interest in what doctors do and getting to hear these really intimate stories that we don't talk about publicly.
No, we don't talk about a lot of it because we're also not allowed to.
Thank you so much, Siri, for sharing all of this with me. It's been very enlightening. All of it, every little piece of it.
Thank you so much for having me, Christina.
Oh, you're welcome. Thank you for saying yes. Maybe we could do it again sometime.
Maybe. This was really fun.
Well, I'm glad you enjoyed it. And for anybody who would like to follow up with Siri and see what she's doing on Instagram, because you were very active on Instagram, and it's a good mix of fun, entertaining stuff and actual real medicine, right? You can find her at Hey Siri MD on Instagram. So look her up.
Thank you. Appreciate it.
Bye.
Bye.